Thank you very much, Dr. Loy, for the kind introduction. And I'd like to thank Professor Ayman and the organizers for inviting me to speak today about a topic that's very close to my heart. It's primary immune deficiency disorders. And the new name for that is inborn errors of immunity. So the overview of my talk, I will be speaking about the definition of primary immune deficiency disorders, the most recent classification, when to suspect and how to investigate. I will speak in more detail about severe combined immunodeficiency, which we regard as an emergency, and about antibody deficiencies, which are the more common primary immune deficiency disorders. I will touch on combined immunodeficiencies with associated syndromes and about PID treatment options. So what are primary immune deficiency disorders? There's actually a very heterogeneous group of disorders of immune function and regulation. They're characterized by increased susceptibility to infection, as well as predisposition to autoimmune disease, atopy, autoinflammatory conditions like lymphoproliferation, granulomas, and malignancies, highlighting the importance of the immune system, not only in fighting infection, but in recognizing self, in controlling inflammation, and in fighting tumors. By the end of 2020, about 460 individual inborn errors of immunity have been defined, each attributing to a different phenotype. So they're no longer regarded as rare as we thought, with a prevalence ranging between 1 in 10,000 to 1 in 50,000. And the higher prevalence is attributed by more understanding, more knowledge, we're looking more for them, and better testing, including genetic tests. They range from very mild conditions like selective IgA deficiency, which we don't even regard as an immune deficiency, to severe forms like severe combined immunodeficiency that are fatal if not treated before the first year of life. So this is the International Union of Immunological Society classifications. They're classified into 10 different groups. The first one is immune deficiencies affecting cellular and humoral immunity, or combined immune deficiencies, combined because they affect both T and B cells. Then we have the combined immunodeficiencies with syndromes. The third one is the antibody deficiencies. Then we've got the phagocytic defects, so like the congenital neutropenias or chronic granulomatous disease. Then we have the defects of the innate immune response. And these defects are usually predisposed to a certain infection. So you'd find one like, for example, the defects in the interferon gamma or IL-12 pathway predisposed to mycobacterial infections, or ones like dectin-1 that would only predispose to fungal infections. Then we have the autoinflammatory disorders where the inflammation cannot be switched off. And our typical example is familial Mediterranean fever. We've got the complement defects, the bone marrow failure defects, the primary ones have been added to this group. And we've got the phenocopies of primary immune deficiency, where the defect is not in the gene, it's either a somatic defect or you have autoantibodies to one of the immunological molecules. And there are some patients where they have the full clinical picture and lab features, but we don't get a genetic diagnosis. And these are regarded as unclassified PIDs. So this is data from our cohort in Tawam Hospital about the distribution according to classifications. Worldwide, the most common is antibody defect, but in our cohort, it was the combined with syndromes. And this highlights that people are aware, most of that was DiGeorge, they're aware to refer to us DiGeorges to look for immune deficiency. We have also a high percentage of combined, that's 20%, and that's most likely due to the high rate of consanguinity in this population. I think the antibody deficiencies are lower than what we expect because we deal with a pediatric population, and antibody deficiencies are more common in adults. So when would we consider an immune deficiency? These warning signs were published by the Jeffrey Modell Foundation in 2011. And they mentioned, it's a rough guide really, it's not very precise. If you get 4 or more new ear infections per year, 2 or more pneumonias, or 2 or more sinus infections per year, if you have 2 or more deep-seated infections like meningitis or sepsis, if you have a deep-seated abscess or an organ abscess, if you need IV antibiotics to clear an infection, if you're on antibiotics for 2 months or more, If an infant is failing to thrive, if they've got oral thrush or persistent superficial fungal infection, or if there is family history of primary immune deficiency. And the one I highlighted, the most sensitive of these indicators or markers is family history. So if your patient especially has a sibling with primary immune deficiency, they need to be checked. And the earlier they're checked, the more likely you're going to pick up a diagnosis early and treat before they get complications. So other than infections, what else do we look for? If they've got unusual characteristic features of a syndrome that we know is associated with primary immune deficiency, like DiGeorge or ataxia telangiectasia, unusual organism, if somebody presents with pneumocystis pneumonia, they can't be immune competent. If they have EBV infection persisting for more than 6 months or disseminated CMV infection, for example. If they have complication of infection like bronchiectasis, you need to look for a primary immune deficiency. Or lymphoid malignancy, especially if EBV driven, would make you want to check their immune system, or if they have multiple autoimmune disease. So how do different groups present? Typically, antibody deficiencies present with recurrent bacterial cyanopulmonary infections or chronic diarrhea. They're not specifically predisposed to viruses except in enteroviral infections. So they can get chronic diarrhea. We commonly get prolonged rota viral infection after vaccination. The complement defect, if you have a defect in early complement like C2 to C4, you will get recurrent infections with encapsulated bacteria, where that the late defect C5 to C9, they get recurrent Neisseria, so would get meningitis twice in their life, for example, due to Neisseria. And complement is very important in clearing immune complexes, so they may have a lupus phenotype or something like atypical hemolytic uremic syndrome. T-cell defects get all kinds of infections from bacteria, fungi, prolonged viruses, as well as autoimmune disease and malignancies. Phagocytic defects typically present with recurrent bacterial infections like abscesses, staph, pseudomonas, and fungal infections as well. And CGD presents with an autoimmunity like inflammatory bowel disease. NK cell defects typically present with recurrent herpes infections. And they can present to any clinic, to the pulmonologist with recurrent pneumonias or bronchiectasis, to the ENT doctor with sinusitis and recurrent otitis media, gastroenterologist with autoimmune enteropathy, or IBD, especially early onset IBD. If it's less than 5 years, you need to look for a primary immune deficiency. And to the hematologist oncologist with multiple autoimmune cytopenias or lymphoproliferation, or to any of us really. So we need to think about them. So the way we investigate them depends on their clinical presentation. And something I highly encourage is looking at your CBC. We're very good at looking at neutrophils, but we forget lymphocytes. Please look at the lymphocytes and see, are they lymphopenic? And is the lymphopenia persistent? The same, is the neutropenia persistent? Is it congenital neutropenia? We can, if we suspect chronic granulomatous disease, there are 2 tests, the nitrobrutazolium or dihydroamine test that we can do. And if there's delayed separation of the cord in presence of recurrent skin infections, we need to look for leukocyte adhesion deficiency by checking the receptors by flow cytometry. For the complement defect, we can test for the classical and terminal pathways by CH50 and by the alternate and terminal pathways by AH50. And depending on the results, we can check for the individual complement components. For antibodies, remember to check all of your immunoglobulins, IgG, A, and M, and don't forget IgE. You can check your immunoglobulin subclasses, your IgG subclasses. And as immunologists, we test responses to Pneumovax, a polysaccharide antigen, and that gives us an idea of how antibodies work. For combined defect or lymphocyte deficiency, please look at your lymphocytes on CBC. And the most important test is lymphocyte subset analysis, looking for your CD4, CD3, CD8, and CD19 population. And then we can do specific tests like response to mitogen or TREX. So if you do lymphocyte subsets, when you suspect, for example, a severe combined immunodeficiency, this is what you'd get. So CD3, CD4 is your T helper cells. CD3, CD8 is your cytotoxic cells. Your B cells are CD19 positive, and your NK cells are CD16, 56 positive. Depending on what we find, you can look for specific proteins like the Bruton tyrosine kinase in the X-linked agammaglobulinemia. And we also can do, or we frequently are now doing genetic testing by looking through next generation sequencing in specific panels, or doing whole exome or even whole genome sequencing in some cases. So I'm presenting a case from our cohort. This is a young boy who presented to us at 3 months with, well, he started at 3 months to have recurrent oral thrush and recurrent fever and was getting frequent antibiotics. He presented to us at 6 months with fever, cough, and oral thrush and was not responding to IV antibiotics. He also had multiple subcutaneous nodules and induration at the BCG site. He had received his vaccinations normally, including BCG. That was his chest X-ray showing bilateral infiltrate, and he was ventilated at the time. But if you look, he doesn't have a thymus. He doesn't have a thymic shadow. And that for us is a hint for severe combined immunodeficiency. And his CBC, his lymphocytes were entirely normal, which was surprising to us, but he had no immunoglobulins. He had absent immunoglobulins. When we proceeded to look at his lymphocyte subsets, if you look, he has very, very low CD3, CD4s, and CD8s. So completely absent T lymphocytes, but he has B cell lymphocytes, and they were high, they were compensating. And that's why he had a normal lymphocyte count. But not all SCIDs would have, a lot of them would have lymphopenia on a CBC. So he's a T negative, B positive SCID. We started him antimicrobial antibiotics. The nodule, unfortunately, was positive for acid-fast bacilli. So he had disseminated BCG secondary to his live vaccine. And unfortunately, he did not survive. He didn't make it. So what is severe combined immunodeficiency? It's a deficiency in T cell number or function. And even if the B cells and natural killer cells are present, they don't work because they need T cells to work normally. We regard it as a pediatric emergency. Atypical forms exist and they present later in age. But again, they're very serious and they present more with autoimmune disease. They can get persistent viral infections, fungal thrush, they fail to thrive. And in our population, disseminated BCGiosis is a problem. What you find is low lymphocytes, low immunoglobulins, and really absent or very low T cells and reduced T cell function. And in the right setting, you may consider HIV because it's a differential diagnosis. We need to isolate them, start them on antimicrobials, involve ID very early, and PCP is a big thing for us. They need PCP prophylaxis. Mothers should not breastfeed if they've had CMV before. And the only treatment is BMT. We start them on IVIG, but that's only to save time until we get them through to BMT. The primary antibody deficiencies, the common ones are X-linked agammaglobulinemia. So that's your Bruton boy who presents in the first year of life with recurrent pneumonias, recurrent ear infections, chronic diarrhea. You will find low immunoglobulins and low B cells, and the treatment is immunoglobulins for life. Transient hypogammaglobulinemia is very common. So these are young babies around the age of 6 months who lose their maternal IgG, but they have delay in making their own. And usually they don't get infections. They're usually fine with it. They very rarely get infections, or we need to consider IVIG replacement. And usually by 4 years, they recover. Common variable immunodeficiency, I'll speak about in more detail. So this is our second case, a 17-year-old girl who presented to us at 11 years. She had a chronic purulent cough, a really horrible cough, had chronic diarrhea, had recurrent otitis with a discharging left ear, and was failing to thrive. She had clubbing on examination, and she had small tonsils on examination. So her CBC was unremarkable, but she had no immunoglobulins whatsoever. All her immunoglobulins were very low. So we proceeded to lymphocyte subsets, and unlike our first patient, they were normal. She had normal lymphocytes. So we looked at her vaccine responses to Pneumovax, and she failed to respond. So low immunoglobulins in absent function. She had bronchiectasis on CT. We would check for secondary causes of low immunoglobulins like nephrotic syndrome or enteropathies. And in older population, in older age group, think about myelomas, think about lymphomas, think about leukemias when you have hypogammaglobulinemia, because that can be the primary presentation. So we diagnosed her as common variable immune deficiency. We started her on IVIG and erythromycin for her bronchiectasis, and look at her growing. She made an excellent response. So what is combined immune deficiency? It's the most common immune deficiency in older children and adults. Most cases are sporadic, but some, in about 25%, a gene can be identified as the cause. These people have low IgG, and either A or M or the three would be low. They can present with recurrent infections or some forms of autoimmunity, or granulomas or lymphoproliferation, or they can have an affected family member. And you would find that they do not respond to vaccines. You diagnose them above the age of 4 because you need to make sure it's not transient hypogammaglobulinemia. And you need to exclude a T-cell immune deficiency because it might be part of a combined immune deficiency. And the secondary immune deficiencies you need to exclude are drugs, which are now common. So things like rituximab, cyclophosphamide, prolonged steroids, or lymphoproliferative disease, or protein-losing state like nephropathies, enteropathies, and congenital lymphangiectasia. So the immunodeficiency with associated syndromes, pediatricians, I think, are good with that. So the ones to consider looking at their immune system is Wiskott-Aldrich syndrome. Your young boy who presents with severe eczema, a bleeding tendency with thrombocytopenia and low platelets, they can get a very bad immune deficiency, and most of them need transplanted. The DiGeorge syndrome, where there's a T-cell defect, they're picked up very early. Usually people are very good at picking them up with their cardiac conditions, their hypocalcemia. And the ataxia-telangiectasias, which is really one of the worst diagnoses to give. So these are the young children with progressive ataxia. You get telangiectasias on their conjunctiva, and they have a combined immune deficiency as well. So they need to be checked. So if we diagnose a primary immune deficiency, what are the treatment options? It depends on your diagnosis, really. And it can be something as simple as prophylactic antibiotics in the milder types. Immunoglobulin replacement therapy is indicated for antibody deficiencies and for combined immune deficiencies. There's IVIG, which most of us know about, but there are subcutaneous forms as well, and a facilitated subcutaneous form, where we give an enzyme first and then the immunoglobulin, and it allows us to space the immunoglobulins further. Cytokine treatments can be indicated in some patients. So patients with defects in IL-12 or interferon gamma, they can be replaced with interferon gamma. We also use that in CGD, or GCSF in congenital neutropenias. Enzyme replacement, so ADA, severe combined immune deficiency, we can give them ADA enzyme until we phase them and get them prepared for bone marrow transplant. C1 esterase inhibitor or hereditary angioedema, I think my colleagues will be speaking about that later. You can replace the deficient enzyme, which is C1 esterase inhibitor. Bone marrow transplantation is indicated for combined immunodeficiencies, for phagocytic defects, for some of the syndromes like Wiskott-Aldrich syndrome. And thymic transplant is an option for complete DiGeorges. So most of the DiGeorges have partial T-cell deficiency. Part of the thymus is working or is present, but those who have complete DiGeorge, they behave like a severe combined immune deficiency. And if they don't have a donor for BMT, a thymic transplant is an option. Gene therapy has moved a long way in primary immune deficiency defects and is now commercially available for ADA SCID and is in trials for X-linked SCID, CGD, and Wiskott-Aldrich syndrome. So as non-immunologists, what can we do? So please consider primary immune deficiencies if you have anybody with serious, recurrent, unusual infections or a persistent infection, if they have autoimmune disease, especially if multiple autoimmune disease, and if they have a lymphoproliferative disease, especially if EBV driven. On a CBC, check your lymphocytes and look back and see how have they been a long way back. Check your neutrophils, and again, look and see how they've been over time. Immunoglobulins are testing, they're quite cheap. So it's a good test to do. It's cheap and it picks most of the immune deficiencies, especially in older children and adults. So check in anybody with recurrent sinopulmonary infections with bronchiectasis or with chronic diarrhea or failing to thrive. If you're suspecting a combined immunodeficiency, look at your lymphocyte subsets and immunologists are available for consultation. Thank you, and I'm happy to accept questions.